So the bottleneck is no longer choosing the right test, right? The right test is usually the same in most circumstances. Yeah, test all the genes. The bottleneck is to use those test results, interpret them in a nuanced way, and use medical judgment to help families to decide exactly what are the right medical decisions contingent on the genetic results. So what that means, the implication of that is that the testing potentially could move earlier in the process and not wait on a geneticist who already knows in advance likely what the test is going to be that gets ordered.
Genetic testing is no longer a distant specialized tool reserved exclusively for rare disease clinics or academic centers. Genetic testing is now showing up in the everyday rhythm of pediatric practice. For example, we're increasingly considering genetic diagnoses in children with developmental delays outside the normal range. And a NICU graduate seeing you for the first time in clinic may already carry a genetic diagnosis based on testing done in the nursery. What does the practicing pediatric provider need to understand about the ordering and interpretation of genetic tests? In this episode, we unpack how community pediatricians can make sense of the world of genomics. This is Charting Pediatrics. Joining us for this robust conversation are doctors Austin Larson and Margarita Saenz. Dr. Larson is a pediatric medical and biochemical geneticist. He is the medical director of Precision Medicine Clinical Informatics, as well as the director of the Mitochondrial Care Network Clinic here at Children's Hospital, Colorado. Dr. Saenz specializes in clinical genetics and dysmorphology. She is the medical director of Precision Medicine Education and Family Engagement. Both are on faculty at the University of Colorado School of Medicine. Austin and Margarita, welcome to the podcast.
Thank you.
Thank you for having us.
Margarita, first question for you. What are some of the advances that have made genetic testing more accessible to our patients?
Yeah, I think that's a wonderful question, thinking the evolution over the last 15 years has been very expansive with regard to the high types of resolution of genetic testing, still persistent challenges in things like accessibility to different underserved populations, certain insurance barriers. But I think having these open dialogues and talking to our community providers that they can, in fact, order these tests and initiate even before they send a genetics consult.
And the science has really advanced and changed. And I remember from early in my career when we would send a test for looking for a single specific mutation to now exome sequencing and full genome sequencing. Austin, how's that changed the diagnostic approach in your field?
Well, we went from having tests that were really broad but low resolution. So that was like looking at chromosomes. We could diagnose things like Down syndrome or Turner syndrome. And then we got a little bit better at the resolution and we did chromosomal microarray. So microarray has about 20% of the diagnostic yield of genome sequencing. So 20% of the genetic changes that are clinically relevant are deletions or duplications of genes, but 80% of them actually require high resolution testing to sequence the genes. As you said, that used to be a really targeted process. It was really expensive. And most of what we did in genetics was to choose between thousands of different tests that were available to try to throw a dart at just the right place and pick the right gene to sequence. But genome sequencing combines both the breadth of the entire genome as well as the high resolution of going through and sequencing every single base. And when you combine those two, you have a really highly sensitive test to look for most of the known mechanisms of rare diseases.
So Margarita, this is a big change, right? I mean, you asked about whether or not a specific mutation was present. Yes or no answer, right? Essentially, now you're dealing with the entire genome's worth of information. So give us a sense of the computational and analytic side of these tests and what's involved on the back end after, the sequencing machine does its work.
Right. And so when we get our test results back, that's when it really starts for the interpretation, where we counsel families that you can get 5 different types of answers. You might not get an answer. You might get an unclear answer called a variant of unknown significance, or something pathologic that I call a troublemaker. And things in between where it's not quite clear. So there's a depth of different types of results that we can get, and educating our families in that way beforehand, I think, helps with that, so they know what to expect.
And you mentioned accessibility in populations, but there's also the issue of the representative populations that we compare to. How does that play a role in terms of identifying your troublemakers versus your variants of unknown significance?
Yeah, so the other thing to keep in mind is that when we take a DNA sample, we're comparing it to what's normal. Well, in the majority of the databases, there's a large component of individuals of European ancestry. So if we have families that are not of primary European ancestry, we say you might have more variants of unknown significance. Certain efforts from the National Institutes of Health with like NOMAD are working to improve those representations. And I'd like to think Children's Hospital Colorado is helping with that with equitable services across the board.
Yeah, so we're getting better, right, in our resolution, but then also our benchmarking, if you will, to the rest of the general population. It's an amazing amount of data that we have to comb through. So, Austin, as we think about the landscape of genetic testing, I mean, we know that by and large, as we started our careers, these were tests that were ordered by folks with clinical genetics expertise. The field's evolving. So what are the latest society recommendations about how we approach the question of when genetic tests should be ordered?
So there are new guidelines as of 2025 put out by the American Academy of Pediatrics, stating that patients with intellectual disability and or autism should receive whole genome sequencing as a first tier diagnostic test to try to figure out the basis of their developmental differences. So when we were talking earlier about what's the difference between genome sequencing and earlier generations of testing, we talked about how the role of genetics was really to think very, very carefully about where we want to use our very limited testing resources and how we want to direct that based on an exhaustive physical exam and medical history. But that's not the bottleneck anymore. So the bottleneck is no longer choosing the right test, right? The right test is usually the same in most circumstances. Yeah, test all the genes. The bottleneck is to use those test results, interpret them in a nuanced way, and use medical judgment to help families to decide exactly what are the right medical decisions contingent on the genetic results. So what that means, the implication of that is that the testing potentially could move earlier in the process and not wait on a geneticist who already knows in advance likely what the test is going to be that gets ordered. But if we evaluate the patient with results in hand, we have the potential to be one step ahead in terms of helping the family to use those results and really have an impact on medical decision-making going forward.
So really moving up the genomic testing earlier in the diagnostic process, potentially in the hands of a general pediatric provider in the community who is very, very well-versed in making the diagnosis of developmental delay, autism, et cetera, but then allowing our genetic specialists really to help with the interpretation and perhaps some of the discussions with family. Is that the future as you see it?
Yeah, and that may not be the present for everyone. So there will be a lot of folks who feel discomfort when they hear that proposed workflow, both inside of genetics and in general pediatrics and in other specialties. But I think that just makes sense as the trajectory going forward.
Let me ask you an additional question from a genetics specialized person like myself. But so let's take that example of a patient who has developmental delay, perhaps autism. You send whole genome sequencing. Does the analytics team focus on that suite of genes that has been identified and is associated with those versus looking at all of the base pairs in our entire system? Like, how does that the clinical question focus the interpretation?
I think that makes a great point, which is that genome sequencing has a lot more in common with a specialty consultation than it does with most other lab tests. So with a lot of lab tests, there's just a numeric or a binary result. The microbe is present or absent. The sodium is 145 or 143. Right. But in this case, it really is a clinical consultation, and you're asking for the judgment and expertise of the folks who look through genomic data all day, every day. So just to kind of give you a sense of the scope of this, when you open up the genomic data, there are 5 million results. So you have to go from 5 million results where someone differs from the reference genome and figure out the one or two of those that are clinically relevant for your patient. So we're relying on a lot of judgment. There's a lot of AI and computation and algorithm that goes into that. But at the end of the day, there's a substantial amount of clinical judgment and expertise on the part of the folks doing the analytics in the lab to help us to pick out that one or two results from the genome that are really going to help to answer the clinical question that the clinical team has.
Right.
And I think it affords an important opportunity to partner with our community providers in filling out that requisition form, as the terms that we put on the form for the genetic testing helps the lab which genes to look at. So if it's developmental delay or if it's an epileptic encephalopathy, that's going to change the scope of what genes they're looking at, and also lends itself to the idea of a dynamic genomics result that over time, if the phenotype changes, we can go back and reanalyze, which is also included in the guidelines that we need to consider. Once you get your result, following the patient, if things change, you can always go back.
That's fascinating, and I think important for our listeners to know that with whole genome sequencing, you don't have to order the test again. If the clinical circumstance changes in 5 years, you still have the bank of data, if you will, for the patient. That obviously isn't changing over time, but you may reinterrogate the data based on what's been discovered in the last 5 years and based on the patient's newly identified symptoms. Does I have that right?
Exactly. And a beautiful example comes from a little girl I've followed in clinic for the last 15 years. And just this week, we found an answer for her for a gene that was discovered in 2022.
Right.
So
because we're constantly making these observations of what may have been variants of unknown significance, then becoming more clearly identified as the troublesome. Speaking of the language that you used to describe to families, I thought that was very interesting because pathologic mutation, it just sounds differently. It sounds very medical terminology-esque versus a troublemaker. Yeah. I find the whole concept of explaining a very complex test that is even hard, frankly, for us as medical professionals, some of us, to understand. But the task of explaining that to families is something that you focus on a lot in your work. So what are some other ways that you explain what a child is about to undergo? And then you oftentimes have to get the parents tested as well. So how do you engage in that conversation?
Yeah, so I outlined the 4 goals of a genetics visit. Is 1, are you a candidate for diagnostic testing or not? And if so, what sort of tests should we choose? The reasons why parents and providers might consider genetic testing include there's going to be a specific treatment or intervention based on a molecular diagnosis, whether that's supportive or moving to precision medicine interventions. Then third, that's a big driver for a lot of folks, is prognostically, I'll say, how's this going to impact your kid in the future? Could it mess with your thyroid? Could it impact the kidneys? And then the 4th realm is recurrence risks. So not just for your generation, mom and dad, for example, but could it impact junior? Should they decide one day to have a biologic family? And all of those words are very specific and intentional because things like families are made all sorts of ways. Who knows if junior will pursue that? So those are the four that I try and cover.
One of the questions that I think comes up frequently around whole genome sequencing is that you're getting information about a patient that may not be directly tied to the clinical problem or the symptom that you're investigating.
Mm-hmm.
You know, I don't know how you describe those incidental secondary findings. How do you approach that conversation, that discussion, and what information gets disclosed, what doesn't get disclosed to families?
So first of all, we have an incredible group of genetic counselors that we work with. So that's a really integral group here at the hospital. And they do an incredible job of making genetic testing available, both inside and outside of genetics clinic, also making these concepts accessible to the patients and families that are undergoing testing. A couple things I'll mention. One is that there's a technical definition of a secondary diagnosis versus an incidental finding. So secondary diagnosis is a specific list. So that's a curated list. The American College of Medical Genetics has currently 84 genes that have the characteristic of being actionable. So things like Huntington's or Alzheimer's predisposition, that's not actionable. There's not a specific screening regimen. There's not a medication that you would start in a pre-symptomatic state. Things like long QT syndrome or BRCA1, those things are actionable. There's an agreed upon screening regimen or a medical intervention that would be implemented at a certain point pre-symptomatically. The other characteristic of those genes is that we know them well. We know the genetic landscape of those genes. They're relatively unlikely to have a variant of uncertain significance. So if someone is opting into secondary diagnoses, they're not going to get an uncertain result. It's either going to be a clearly diagnostic result or a negative result for that category. Incidental findings are sort of off-target things that are not specifically curated for that secondary diagnosis list. Things like non-paternity, if one of the parents is not biologically related to the child. There are some other examples, like if we're doing a more targeted test, but the quality control of that sample reveals a chromosomal difference for the child, that would be an incidental finding. That's not a secondary diagnosis. So that there is a technical definition there, and families can opt in or out of secondary diagnoses when they do genome sequencing, but incidental findings are always kind of a small risk of participating in genetic testing.
So it sounds to me like there's a pretty robust ethical framework around this that you guys all adhere to in terms of how you report these different kinds of results.
I think the informed consent process can be another area where providers are less comfortable without knowing those nuances or how it can impact our military families that don't have certain the just non-discriminatory protections or certain things like life insurance or long-term disability insurance, right? We know with Gina from 2008 that people can't be discriminated against based on their medical diagnosis for medical insurance, but those other areas are not protected. Mm-hmm. So those are all very important. And I think informed consent can be a barrier to testing.
So I'd like to explore for a second our experience with using whole genome sequencing for patients with developmental delay, neurologic atypia, because now we have several years of pretty robust experience implementing that. Mm-hmm. Austin, what has been our diagnostic yield using whole genome for that type of problem, which I think actually is something that our pediatricians all see, right, in their offices?
It is, yeah. So that's the single most common indication for testing. Answering the diagnostic yield question is very challenging because it really depends on ascertainment. So if you include mild intellectual disability or borderline IQ, the yield of testing for monogenic or Mendelian diagnoses goes down. Okay. If you're looking at autism in the setting of a typical IQ, as opposed to autism with concurrent intellectual disability, the diagnostic yield is going to be much lower. Okay. So there are if you focus on kids with moderate intellectual disability or moderate developmental delay, a lot of studies come in at like 30 to 40% diagnostic yield. In practice, what we find is that it ends up being lower than that because we tend to broaden the ascertainment more than these carefully selected cohorts of research participants.
So maybe this isn't the right way to say it, but the severity of the phenotype may dictate your yield in some of these cases.
Yeah, even some of the guidelines have said that the children with autism, non-syndromic or non-systemic, do have those lower diagnostic yields. But then some numbers like in 2021, when exome came out as a recommendation for multiple congenital anomalies, recognizing that exome testing yields a result about a third of the time, where previous panel testing was only about 19% diagnostic.
And Austin, you mentioned in the AAP recommendations to use whole genome for the autism and developmental delay. Are there other clinical phenotypes where whole genome is recommended right now?
Yes. Multiple congenital anomalies is often an indication. I would say that's probably our number 2 indication for genome sequencing. There's an evolution in the field right now about when a scenario is appropriate for panel testing versus genome-wide testing. And so that's really a work in progress. A lot of the payers have specific indications around epilepsy, autism and intellectual disability, multiple congenital anomalies as their clearly covered indications for genome testing. Some other scenarios, we may be asked to use a panel test or a more targeted test, for example, cardiac arrhythmias or structural heart disease or ocular diseases. But what we find is that the negative predictive value is really hard to interpret when you're doing something more targeted than whole genome sequencing. So the question is, if you get a negative result for a child that very clearly has, say, retinitis pigmentosa, is it a negative result because the patient truly does not have a Mendelian or monogenic disease? Or was it a negative result because the data set that you analyzed didn't actually assess for the appropriate genetic mechanism?
Interesting. So you brought up the issue about kind of payer rules around this. And I'd love to get your guys' perspective on where we are today and where we see this evolving. Obviously, insurance kind of payer decisions, payer algorithms can evolve relatively slowly over time, but this is a field that's moving incredibly quickly. So, and this can impact access, as you said, Margarita. So where do you guys see this standing now and where you see it evolving? And the one thing I'd like you to include in this is, obviously, the payers are motivated by controlling their costs, but the cost of whole genome has fallen dramatically over the last decade. So where does this balance out in the future?
I think I've had personal experience with insurance companies wanting to develop guidelines and understand when treatments might be indicated for conditions like Rett syndrome that have precision medicine interventions or things like that. They're seeking to create their own guidelines, I think, with their goals in mind, but also the fact that they're seeking consultations from the experts is a good thing. Historically, a lot of the private payers would refer to genetic testing as experimental, and I would smile and say, I call it a career.
So, how kind of you to smile in those conversations.
But
I could imagine a different response too, but that's very, very noble of you.
But with that, I think I'm hopeful for progress and advocacy to get better coverage.
Yeah, we've seen a lot of progress in recent years. So as Margarita said, we used to get this response all the time that this is experimental. That happens less and less now. It's more just that the data support these specific scenarios, and we don't have as robust of a published literature around these other scenarios like retinopathy or structural heart disease or things like that. There's more and more publications coming out about not only the diagnostic yield, but also the clinical utility. And I do want to make the point that those are two very separate things. So the diagnostic yield, you can have high diagnostic yield if you use a test in a really targeted way. Like I could have a yield on the genome sequences that I send of 80%, but what that would mean is that I'm severely underusing the test. Yeah. And there are a lot of patients.
You're limiting it to patients that have a fairly obvious phenotype.
Yep.
Okay.
So a low diagnostic yield does not necessarily mean low clinical utility. There are a lot of scenarios where doing the most sensitive test for rare diseases means that if you get a negative result, you then can proceed on a different pathway and consider different categories of diagnoses, and actually move forward, knowing that you did the most sensitive possible evaluation for monogenic diagnoses.
That's an important point and a nice segue when I think about genome testing in the NICU and sort of these rapid turnarounds that we're getting, and the data and evidence show that they do impact medical decision-making or various other diagnostic evaluations. So there's a ton of information and ultimately can lower the cost of intervention.
That was actually going to be my next question for you guys, is how is this being utilized in our nurseries and NICUs right now for the clinical teams and families? What are you guys seeing on a everyday basis?
Well, this is a good opportunity to make the exciting announcement that we're bringing rapid whole genome sequencing, or what we call critical whole genome sequencing, in-house as of next week. So that goes
live
at
our hospital.
At our hospital, yeah.
Yeah, that's great.
That goes live next week. And up until now, that has been a send out. So it's a really challenging process to stand up in the lab. You have to have folks both in the wet lab and on the analytics side on call, working over the weekend. You really have to change the structure of how the lab works. You have to have excess capacity in order to be able to always reliably have a 4-day turnaround on whole genome sequencing. Up until now, we've been working on other aspects of the lab. And so that's been a send out test if we needed a 4-day turnaround whole genome result. But next week, we're going to switch to doing those tests in-house. And that rapid whole genome sequencing really does have, I think, the best use case for an in-house test. Margarita earlier mentioned the idea of a dynamic genome analysis that continues to answer different questions over the course of using that genomic data. And that's particularly important in the NICU because if we send a test on the first day of life, that patient is really undifferentiated, right? We have very little data about exactly what are the medical problems that are causing a child to be in an ICU. And then over the course of the next couple of days, things become clearer. You get an echocardiogram, you get a brain MRI, you get a whole series of blood tests and other diagnostic evaluations. But we want to have the genome cooking while that process is playing out, right? We can't afford to wait to the point that you made earlier. If we wait until we're pretty sure what the answer is, we're probably too late to intervene in as meaningful a way.
So that's incredible news, Austin. And when this podcast actually airs, we'll have this up and running and probably have sent this on a number of babies in our NICU, which is, I mean, for those of us that have been in practice long enough, this concept that we can have an entire set of genomic information within 4 days is just startling and wonderful, right? Obviously impacting high level decision making for our neonatologists and for families of babies that are critically ill. It's really incredible. I also want to make the point, because we've talked about this idea of going back to the information in the future and analyzing it. It's not like this is like a stored specimen in some freezer. Like you've already done the wet lab part, as you say, Austin. This is really just reanalyzing the data according to what has been discovered and learned, right? There's not any other prep that has to do with the analysis. Am I right on that?
That's right. Yeah. I mean, there's two types of improvements that are happening. So there are improvements on the analytic side. There are folks that are brilliant computer scientists and bioinformaticians who can continually tease more and more nuanced results out of the same data set that was generated in the wet lab. On the flip side, there are also ongoing improvements in the wet lab. There are new sequencing technologies that actually generate a richer data set. So there is some decline in the value of information, of the type of genomic information that we have in 2026. There's some decline in the value of that over time as new wet lab technologies come up.
That makes sense. This is such an exciting field. You guys are poised in this specialty at what has to be the most exciting couple of decades in the history of genomics, frankly, and clinical genetics. What are you guys most excited about in the next 5 years? Austin?
So a couple things we're working on. One is genome-based newborn screening. I want to be clear that that is an opt-in scenario. That's not anything that is happening without a robust consent process. It's also a research-based test. So we're doing that on a research basis for babies born in University Hospital here on the Anschutz campus. There are many other programs around the country and around the world that are using a genome platform for newborn screening. So there are a whole lot of diseases that meet all the criteria for newborn screening, meaning that there's an intervention associated with knowing the diagnosis, that there's a pre-symptomatic state, and that by intervening in that pre-symptomatic or early symptomatic stage, you can alter the natural history of the condition. There are hundreds of conditions that meet those criteria. Only a small subset of them are diagnosable with a metabolite or a biochemical based test on a blood spot. And that scales way up when we introduce genomic technology into newborn screening. That is a hugely involved undertaking, and the devil is very much in the details. We have decades of work to do on exactly how to implement that, but it is happening. There are multiple different research studies going on, and my hope is that we continue to diagnose patients with treatable diseases earlier and earlier when the treatment is the most effective.
Margarita, what are you excited about?
Yeah, when you said that, my first thought was treatment, and to be amidst things that we only dreamt about even a decade ago is a privilege, and it's amazing. The other thing that I'm excited about looking to the future is medical education. I say whenever we find another warrior who wants to help our kids, I'm very excited to educate them and teach them how we do what we do. And also with those workforce shortages that exist, that's where we want to empower our community partners to go ahead and order that testing. We'll be there to support you with the interpretation and management components. So it's a lot.
This has been a really exciting conversation. I've learned a ton. Super wonderful future ahead. Thanks you guys, to both of you, for sharing all of your experience with us today.
Thanks for letting us share.
Yeah, thank you for having us on the show, and thank you for supporting genomics at Children's Hospital.